Dr. Mourar will now show us how to assess primary tricuspid regurgitation. She will first focus on the morphology of the valve and how to assess the morphology and the mechanism of the tricuspid disease, and then she will move on the way to assess the severity of tricuspid regurgitation.
For the echocardiographic examination of any patient with tricuspid regurgitation, you should be able to follow a certain sequence. First, you need to define the mechanism of regurgitation, then to assess its severity, to assess the consequences of the tricuspid regurgitation on the right heart chambers, and finally also to assess the pulmonary pressure. But before starting the exam, you should keep in mind that there are two important things that you should verify first. First, you need to know the patient history very well, because sometimes some clues from the patient history may help you to understand better the mechanism of tricuspid regurgitation, like in this case, as you will see very well. And second, do not forget to measure the pressure, the blood pressure before the examination, as all the Doppler measurements may be confounded by this. So, let's start the examination with the parasternal longitudinal view of the left ventricle, which even if does not allow us to assess the tricuspid valve, gives us important information qualitatively about the size of the right ventricle, which in this case, as you can see, seems normal. There is a normal left ventricle with a good radial shortening, and also the left-sided valves, the aorta and the mitral valve, look quite normal. And this again gives some important ideas about the regurgitation mechanism. Here you see that the aorta is perfectly coapting. Here you see in a parasternal short axis view, while rotating the probe 90 degrees, you see that the aorta is perfectly normal. And most importantly, you can also see that the outflow tract of the right ventricle is free. There is no stenosis, and there is only a mild pulmonary regurgitation. This is another important point in any patient with the tricuspid regurgitation. Make sure that you also assess the pulmonary valve. Here is the parasternal short axis view of the left ventricle, in which you can appreciate there is a normal regional wall motion of the left ventricle. And this is a patient that has underwent a heart transplantation in 2009, has been well ever since, no symptoms, and this is just a routine examination, 1 year follow-up. Then we will try to approach the tricuspid valve by gently tilting the probe towards the right heart, and we will see that there is a clear abnormality of the tricuspid valve. This is a focused view of the tricuspid valve in a short axis. Here you can appreciate the aortic valve, and here you can see this fragment, which has the same structure as the leaflets of the tricuspid valve. However, we cannot tell so much about it, and we need to take a proper look at it. Then, if you would like to add the Doppler, you will see that there is some regurgitation. However, I cannot see very well neither the direction or appreciate the severity of the tricuspid regurgitation. This is important because there is no single view and recommended view for assessing the tricuspid regurgitation. You should be able to obtain optimized views of the tricuspid valve in parasternal short axis view, in the right ventricular inflow view, in four-chamber view or subcostal view, in any views that allow you to have a comprehensive assessment of the morphology of the valve and to assess the tricuspid regurgitation jet. Then, if we will optimize a little bit the position of the transducer in order to appreciate better the morphology of the valve, you will be able to see that here there is a clear abnormality of the one leaflet. If I will freeze the image, you will be able to see that the leaflets are not coapting. There is a large coaptation defect between this one here and this one staying upwards, and there is significant regurgitation at this level. Well, then if we will move now to the apical views, again, to assess better the tricuspid valve, you should ask the patient to lean a little bit on his right side in order to be able to accommodate the probe in the apical view. And then we are able to see the tricuspid valve, and you see that there is a clear morphological abnormality. However, it's not clear which is the leaflet that is involved. Seems to be on the septal side. However, it's not clear if it's really the septal or the anterior leaflet. We can adjust a little bit the position of the probe in order to have a better look of the tricuspid valve. Here again, however, not so many informations. And remember, there is also the possibility to approach the patient from the subcostal view for assessing the morphology of the valve. So please stay on your back. Okay, and then we can try to assess again the morphology, and we have the confirmation of an evident structure abnormality of the valve, which results also in some degree of tricuspid regurgitation, which is not very clear. Probably in this case the jet is very eccentric, and we should be able to obtain a better view. However, all these views of the tricuspid valve have the problem that in each two-dimensional images, the tricuspid valve has only two leaflets that we can see, and we are not able to tell exactly which are those exact leaflets. So the individualization of the leaflet involved in this case should be better done by 3D acquisition. So I would now switch the probe to the 3D probe, and then I will select the probe here. Okay. And then I will ask the patient to lean on his left side again, and I will acquire a 3D acquisition of the tricuspid valve, in which this is the tricuspid valve as seen from the right atrium, the so-called surgical view. Here is at the left part of the panel, you can see the mitral valve. Here on top is the aorta, and here is the tricuspid valve. And you can see that there is a clear abnormality which involves the posterior leaflet. So the 3D echocardiography allows us to have a better identification of the leaflet involved, because it's the only modality that we can have for the tricuspid valve to obtain an en-face view from the right atrial perspective, as the surgeon does in operating table. So the conclusion after this comprehensive assessment of the morphology of the tricuspid valve is that the origin of the regurgitation is a flail valve. And given the fact that there is a patient with a heart transplant, it may be that the patient during one of his recent biopsies had a trauma by the bioptom used for endomyocardial biopsy, which is not so infrequent finding in these cases. Then, if I will switch again the probe for scanning in 2D in order to assess the severity of the tricuspid regurgitation. Okay, in the 4-chamber view this time, placing the probe in the apical region, and then I will select the color flow mapping, and you can see that there is a highly eccentric jack that we can appreciate also simultaneously side by side with the 2D imaging of the valve. And you can see very clearly that the flail of the posterior leaflet, which have was identified by 3D echo is the mechanism of this highly eccentric jet that you can appreciate more easily in a still frame like in this. So basically, when you have a clear evidence of a flail, you should be absolutely sure that the severity of that tricuspid regurgitation is clear. So no additional quantitation is needed. However, for demonstration purposes, I will go through all parameters that are recommended in the guidelines by the European Association of Cardiovascular Imaging to show you which should be done in order to assess quantitatively and semi-quantitatively the severity of the tricuspid valve. So first of all, let's see the color flow Doppler. In this case, in organic tricuspid regurgitations, since there is a swirling jet across the tricuspid valve that goes through the wall, the lateral wall of the right atrium, it is very likely that this jet can be underestimated. So the color flow and the area jet in this highly eccentric jet are not recommended parameters to assess the severity of the tricuspid regurgitation. The second point is the fact that the color flow, as you can see here, for instance, if I change the gain of the color and I increase it, seems larger, and if I reduce it, it will seem significantly lower. This means this is a limitation of the color flow mapping, and this means that the color jet area is highly variable with the gain settings that we have on the scanner. For this reason, it is recommended that instead of assessing the color and the jet area, one should do the PISA method. What is the PISA method? So after acquiring the color Doppler, then you can freeze the image, you can zoom the image in order to see better the proximal convergence of the regurgitation, and then you should be able to decrease the Nyquist limit, which you can see here in the middle. Now I am reducing it, and I'm reducing it to 29, which is the recommended cutoff in the guidelines. And then after selecting the best frame that I can identify in systole, then I'm able to identify the three components of the regurgitant jet. The first is the proximal one, the PISA, this one here, in this region. Then there is the vena contracta, which is the neck of the regurgitation, and then there is the jet in the right atrium. One quantitative parameter that is recommended in the guidelines is the PISA radius that can be measured from the base of the hemispheric surface area until its top on the first convergence zone. In order to better identify the base of this hemisphere, it's very helpful to remove the color like this in order to see where the valve stands, and then to put it again. And once you have identified that the base of the hemisphere is in this place, you can select the measurement, the caliper, and then you go and measure the radius of the first convergence area, which in this case is 12. The cutoff for severity is 9, so this is suggestive of severe tricuspid regurgitation. Again, this is for demonstration purposes. The flail by itself is a very important criteria of severity. Then another important semi-quantitative parameter that we can obtain is the vena contracta. On the color Doppler, what you need to do is again to zoom the image, okay, then to freeze it in systole in a representative frame, The Nyquist limit in this case should be between 40 and 70. And then you can select the caliper and measure it, paying attention that your measurement should be exactly perpendicular to the orientation of the jet. This is especially important exactly for the most eccentric jets, which sometimes may pose some problems in the quantitation. After performing the color Doppler examination, then we can provide some new insights by looking at the continuous Doppler. You will see that in this case there is an important, a very intense envelope with an early peak, and also with the notching, with a cutoff sign, which is highly suggestive of a severe tricuspid regurgitation, which does not exceed 2 meters per second in maximal velocity. And this, together with the pulsed Doppler wave profile, which in case of our patient, this has this aspect with E and A waves are fused, you can see that the velocity of the fused waves is somewhere around 1 meters per second. Again, the velocity, the antegrade velocity of the E wave is increasing in proportion with the severity of the tricuspid regurgitation. So the larger the severity, the higher the E wave velocity. And the cutoff for severity is 1 meters per second. However, I would underline the fact that when the patient is tachycardic, like in this case, you see the heart rate is 94, is not a reliable parameter, because with the fusion between E and A waves, the velocity is no longer reliable. Another situations in which the velocity of the E wave cannot be used as a parameter for orienting in the severity of the tricuspid regurgitation are, for instance, in patients who have performed annuloplasties or have a tricuspid stenosis. In that case, the acceleration and early diastole is not only related to the regurgitation severity itself. And to continue, what we can do is to go again in the subcostal view. Please lean on the back again, and we will take a color Doppler flow imaging of the hepatic vein. If I will freeze the image, you will be able to see that during systole, so when the regurgitation occurs, you will be able to appreciate that there is a red color flow within the hepatic vein, meaning that there is a flow reversal, systolic flow reversal in the hepatic vein, which can be also sampled by pulsed wave Doppler. And you will be able to measure the systolic flow reversal, which is this. You see here is the ECG wave, and this is the systolic flow reversal, which is a very, very specific sign for tricuspid regurgitation severity. Then to conclude, we also, as I have mentioned in the beginning, we need to assess also the pressures in the right atrium. And to do this, we need to measure the size and the collapsibility of the inferior vena cava. You see that in this case, the patient does not have a spontaneous collapse. The inferior vena cava seems dilated. We can measure it. And it will measure 22, which is a bit dilated. The 21 is the cutoff for the dilation of the inferior vena cava. And if there is no spontaneous collapse, we can also ask the patient for a sniff test to take a short breath. So take a short breath in. Okay. And you will see that there is no collapse of the inferior vena cava. In this case, it is indicative of increased pressures in the right atrium, and we may estimate from the size and the lack of collapsibility that the pressure in the right atrium is around 15 millimeters of mercury. If we would like to assess also the morphology of the right ventricle and the consequences on the right heart chambers, we can appreciate the fact that from the subcostal view there is the evidence. We can zoom the image of the free wall of the right ventricle, and you can see that there is evidence of the right ventricular wall hypertrophy that we can also measure. So it's 8 millimeters and the normal value is around 5 millimeters. So this may explain why the right ventricle was not dilated. Another reason why the right ventricle was not dilated is probably that the regurgitation is recent and the right ventricle had not the time to dilate. For assessing the consequences on the chambers, I would recommend for assessing the size and the function of the right ventricle to use the same data set that I have used for reconstructing the tricuspid valve. And you can see it here, which provides you a nice overview of the right ventricular function. These are short axis views ranging from the apex of the right ventricle to the tricuspid valve. These are equidistant short axis slices, and these are 3 longitudinal views of the right ventricle. And you can see that there is a quite active contraction of the right ventricle, meaning that probably the regurgitation is of recent onset, and it is probably related to the trauma of a recent biopsy. We cannot perform the quantitation on the machine. We need to export the data and to quantitate it offline with the dedicated software in order to obtain the volumes and ejection fraction. If we don't have a 3D scanner, we can also have the possibility to assess the areas and the fractional area change of the right ventricle. So from a 4-chamber view, you need to obtain a focused view of the right ventricle and to optimize the image quality in order to have a better delineation of the endocardium. Then you will need to stop the image in diastole, and then with the measure you can select the areas, and you can measure the area in end diastole and then in end systole, and accordingly you will be able to compute the fractional area change. The normal value of the fractional area change is 35%. 21.5 is pretty normal, so again confirms the fact that the regurgitation is recent and the right ventricle did not have enough time to dilate. So there is no single parameter, ideal parameter to assess the regurgitation severity. You should be able to integrate the findings from different views and different parameters, and then to integrate them in the clinical context. In this case, given the fact that the patient has a heart transplant, has performed a recent biopsy, the most probable mechanism is a traumatic lesion of the subvalvular apparatus, which led to a severe tricuspid regurgitation.